Hello, welcome to JAMA Network Open Live. I'm Seth Truger, Digital Media Editor at JAMA Network Open.
And I'm Angel Desai, JAMA Fishbein Fellow.
Of course, if you're following along, send us your questions or comments. You can add us on Twitter at JAMA Network Open or put your comments in the comment field in YouTube or Facebook. So our first paper today is the experiences of individuals who are physically restrained in the emergency department. And we've got first author, Dr. Ambrose Wong with us. Welcome.
Thank you for having me.
So great, thanks. Really glad you could join us. This is a really interesting paper on a very somber topic, but obviously important. So tell us a little bit about yourself and why you did the study.
Yeah, absolutely. So my name is Ambrose Wong. I'm an emergency physician by training. I'm an assistant professor of emergency medicine at Yale School of Medicine. And I'm actually an educator by training. I have a master's in education. And when I was developing curricula as I was fellow, the nurses and physicians came to me and said, hey, can we create a training program to help with situations where patients become very agitated, physically aggressive, disruptive? And unfortunately, it's something that's happening more and more often in the emergency department. I know, Seth, you're also an emergency physician, so I'm sure you have had similar situations, unfortunately. And so when I went to the literature, I realized there really wasn't much out there for us. And realizing also that this is a rising problem, but not much awareness has been paid on the topic. And that's how this whole branch of research started for me. I actually started out talking to staff members first, trying to figure out what their situation was like and what their experiences were. And some of the things that they told me were that they had trouble understanding what the patient's perspective was like during these episodes. Were they aware of what's going on? How do they feel? How do we make a connection with them when the situation becomes so volatile and violent that both parties feel threatened? So that's really what motivated us to go and find and talk to these patients.
Oh, wow. That really resonates with me. I think it's one of the things that can be toughest on our shifts, even when the patient's agitated, intoxicated, being mean and aggressive, et cetera. It's still, to me, this I think I try to keep this appreciation about how important and, I don't know, serious it is when we're basically taking away somebody's liberty and exposing them to a lot of potential harm. So, I don't know.
Yeah, it's become such a difficult issue, you know? Sorry, go ahead.
No. Go ahead.
No, I was just going to say one of the things that sort of struck me here was the fact that a lot of the patients that were interviewed felt already that they were coerced to come to the ED. And I suspect that, many of these patients already feel, or there may be some distrust already in terms of the medical system. These are patients that may already be stigmatized.
Yep.
And
Right.
and then furthermore, they didn't really want to go to the ED. And then once they're in the ED, they're restrained,
Right.
unfortunately. And I just wonder if that sort of, cycles or kind of contributes to the cycle of
Right.
distrust and difficulty.
Yeah, absolutely. So tell.
Right.
Oh,
Yeah.
Go ahead.
Sorry. I think we're saying the same thing.
Yeah. So what'd you do in the study? What'd you find? Tell us a bit about it.
So we wanted to talk to these folks to hear their story, their different stories, and also give them a voice. We realized that there really aren't that many studies that were directly from the patients and what they wanted to say. There was actually one other study that was done in Australia that was published in Academic Emergency Medicine, and they interviewed some patients that were just sedated in the emergency department and waiting to see a psychiatrist. And when we read the article, we were really surprised to see that a lot of them felt good. They had positive things to say about their experience. And that's what we hoped for. But I think in reality, working in the ED, it didn't feel that way to me. And so we wanted to see if that was true in the United States or if it was a different perspective. So we sat down with 25 patients that came from all different walks of life and different age groups and socioeconomic factors. There were some that were actually self-law enforcement before. There were some that were working in a white-collar setting. There were some that were homeless. There were some that sort of have recovery from drug use. And they have all sorts of different things to say. But a couple of big things that we took away, I think the first piece was that even though they were getting their physical liberties taken away, they still wanted to be treated like a patient. They're in a healthcare setting. They wanted to see why this was done to them, what's going to happen, and explain why we're doing this. I think that's the first big piece. And then I think the second thing is a big reminder that this is a big deal. This is the worst day of their lives, ever. And that even though we might be doing this day in and day out in the emergency department, that we have to make sure that we're doing it with as much compassion and care as we can, to remind ourselves that this is something that we signed up for and that we're trying to take care of them and not hurt them in the process.
Yeah, absolutely. Going to welcome Thilan Wirjasekara, apologies for my pronunciation, and Min Lakong for joining us. We're talking about a qualitative study on individuals' experiences being physically restrained in the ED. And that's some of the demographics here were really interesting to me. Especially, I think it was one of the respondents was married to an ER doc.
Right. I think divorced at the time we interviewed, but right, yes.
Right, but haven't married, and I think just thinking of I think when we think about patients with agitation, with behavioral or psychiatric problems in the ED, I think my brain first goes to, I think, a lot of stereotypes about socioeconomics, and generally it's not people who are married to physicians.
Right.
And obviously, these are kind of problems that I think more vulnerable populations are likely to have, but they're still cut across all socioeconomics. Absolutely.
I think we immediately think of the person who is homeless or someone who uses drugs and has mental illness. And I think that probably is a big sector of the patients that do come in, like you're saying, that are coerced against their will. They may have an exacerbation of their illness or their drug use. And so we remember those because those are the ones that potentially feel very negative in the experience for us as providers and clinicians. But on a daily basis, and actually we looked at our restraint data when we looked at the electronic health record, and there was actually a big significant portion of patients that are a little bit older who came in actually as a medical complaint. Mm-hmm. They potentially had some mental illness underlying their own individual problems, but the reason they came in was for a medical issue. And these restraints are, unfortunately, they may be necessary, but can be very catastrophic for them.
Mm-hmm. Yeah. Also going to welcome Jeff Blitz has joined us. Welcome. We're talking about restraints in the ED. I know talking to some colleagues in different specialties, it amazes me how much the use of mechanical restraints varies across places. I've heard of a lot of ICUs will use them routinely on all patients, and some of it comes from a good place. You don't want a patient to accidentally get under sedated and then pull out a tube or a line or something like that, or hurt themselves. But it's very, very easy to kind of, I think, for the pendulum to swing too far. Min Lakong sent a comment. Interesting study. Not surprising. The two main take-home messages of compassion and communication. And yeah, I think absolutely. I think you hit the communication point that a lot of patients just don't know what they're going through at all, and so that takes a bad situation and makes it worse.
And it seems like a no-brainer from us talking about this sitting at a desk, at a conference, on a conference call. But I think the struggle is when you're at the bedside taking care of these patients. You feel that tension there. And I think the conversation revolves in our emergency departments around safety for our staff members. And there's actually a bill going through Congress right now to protect both healthcare workers and social services workers in the workplace setting. And this is a problem. We are getting assaulted and injured. And when these situations arise, you feel like this is perpetrated against you. And it feels like an us versus them effect. Because these are the ones that are spitting, swearing at you, throwing punches, and it doesn't feel like a patient sometimes, at the bedside. And the healthcare workers themselves also need better support and training to make sure that they themselves don't become victims. And I think these two issues are overlapping and identical and not two separate problems. And so we have to think about both the patient safety, and it's easy to talk about that. Not easy, it's difficult, but it makes sense to us talking about that. But the flip side is that the staff members themselves are also potential victims.
This kind of makes me wonder a little bit about the evidence base behind restraints. And I don't know if there is a lot of literature out there, but I wonder if there are different types, as a non-ER doc, as the one non-ER doc here, I guess I would ask, are there different types of restraints that people have looked into or thought about just in terms of thinking about those situations and in which you really do have to sort of balance the patient safety and the and comfort as well as the staff. If there are other strategies that can be used, if you're aware of any, I guess.
Yeah, I think unfortunately at the point when the agitation level is so acute and severe, we may have to be sort of all hands on deck, so to speak, to get rapid control. And I think the humane thing to do is to make sure that you administer a chemical sedative at the same time. because these restraints are so physically painful and violent that you have to just make sure that the patient in their own mind is calm and at ease, and also hopefully forgets the situation. Sometimes we forget to do that. And actually, it's funny you say that. I think the restraints have gotten better over time as we realize the dangers of putting on restraints. But the Joint Commission doesn't necessarily give you any specific criteria on the type of restraint. At different hospitals I've worked at, for example, currently where we work at, we actually have restraints that are locked under lock and key. And the city hospital I worked before in New York City, that was absolutely not allowed, just as an institutional policy. And so I think there are some regional variations, and the evidence behind what is dangerous and not is not totally clear, I think.
Right. Yeah, no, it's tough. I would say one of the, I don't know, in my place and most places I've worked, I think there's a much bigger reliance on sedative restraint and not physical restraint. And I mean, I can't think of the last time I've had a patient who had just mechanical or just physical restraints. And I think there's also, I've over the short arc of my career so far, seen the pendulum swinging where, I mean, to really use physical restraints as little as possible, which I think is probably good for everybody. And even in situations where we end up using physical restraints, it's usually just for the very brief period of time while the sedatives are taking effect. And there's, I think, a big cultural attention to getting rid of the mechanical restraints as soon as possible.
I agree. I hope that pendulum continues to swing. Sometimes it's difficult in the emergency department because you may be focusing on that patient as you're putting the restraint on, and then you pulled to take care of a trauma patient or someone that's very medically ill, and you may be in there for a little while, and sometimes you may take a little bit of time to go back and reassess the patient who's been in restraints for a while. The nursing staff and the tech support staff come to us and say, hey, the patient is awake and acting a lot more appropriately. Can we take the restraints off? But there's still a little bit of a delay just because we're multitasking and taking care of a lot of sick patients at once in the emergency department.
Yeah, it's really, really fascinating stuff. Unfortunately, we're running out of time. It's really great having you. This is a really, really great paper. Obviously, an interesting topic. So thank you for the paper. Thanks for doing the great work. And thanks for joining us today.
Appreciate it. Thank you for your time.
All right. Take care. I wasn't able to keep up. There's a bunch more people who joined us. We've got the Boston Children's Hospital Computational Health Informatics Program, Boss Chip, as well as Trevor Hunt, who's joined us. And I feel like I missed somebody. I'm sorry. And Min added a couple comments that in Australia, the hospital beds are a lot more comfortable, which might be a confounder, which is a good point. And I did point out there are lots of different mechanical restraints. I think we tend to use soft restraints in the EDs I've worked in, not the big leather ones with the belts. But basically just the simple soft ones, and basically rely on security guards to get those on. With a lot of people holding patients down. And Min also points out no standardized guidelines, but a good idea for studying aeromedical, where I think I would imagine a lot of it's the potential for, or the window for when things can go wrong and somebody who's delirious or agitated grabs something and it's catastrophic is pretty narrow.
Sure. Yeah. No, and I guess the one other question I would have is, do patients often come in already restrained, or, if they're brought in by paramedics, for example, or is this something that usually happens? And this is obviously anecdotal, but. Yeah.
I'll say in my experience that I've never had, I can't remember EMS providers bringing somebody restrained without police involved. And usually those are just kind of like handcuffs and potentially shackles. And usually there's some level of calmness there, but I think the at least implicit threat of violence from police is a little different than than the medical situation. Which is not a judgment, it's just a different different scenario. All right. So also just want to point out there's a really great invited commentary by Abraham Nussbaum and Matt Winia that gets into a lot of these issues. And I think as Ambrose put it really well, just really just remembering that these are people, they're patients. Most of them or many of them have medical concerns. And treat people like people.
Definitely.
Yeah. All right, so you've got a nice pair of papers to start us off.
That worked out very well.
Go ahead.
So both of these papers look at childhood antibiotic exposure. The first one is Associations of Prenatal and Childhood Antibiotic Exposure with Obesity at Age 4 Years. And actually both of them are from New Zealand, or use New Zealand databases, I should say. So this one, the objective was to look at whether any antibiotic exposure during pregnancy or early childhood was associated with the development of childhood obesity, with a focus a secondary sort of focus looking at siblings and twins. So this was a cross-sectional study. There were 284,000 participants from New Zealand, and essentially it showed that both prenatal and early childhood exposures were independently associated with developing obesity at 4 years of age. That was sort of their cutoff. And interestingly, this was demonstrated in a dose-dependent manner of the antibiotics. So the figure actually kind of demonstrates this, looking sort of both across trimesters in pregnancy, but also sort of across age ranges. And you can kind of see those trends very nicely. The other sort of point here is that when they did a fixed effect analysis of siblings and twins, they didn't actually see that association. So the point being sort of that those particular populations maybe need to be studied a little bit more.
Yeah, it's interesting, and it's hard to know. Is that because when you look at twins and there's no difference, does that mean there's actually no association? This is all a result of confounding,
right?
And the things they talked about were host genetics, maternal BMI, environmental factors, and the infections themselves.
Yes. So, and we've talked about this before too. Like, this is always the trouble or the challenges with these kinds of studies. There's always a concern of residual confounding and confounding by indication. So, it's tough to say what exactly to make of it.
Yeah, it's really fascinating. And I mean, I think with the obesity, or what I know about the obesity issues, is there's so many different things, so many different directions.
Yes.
And so, things like access to physicians, access to healthcare quality, or disparate access to healthcare quality, access to healthy foods, to empty calories, et cetera. All sorts of different things are I think, going to confound a lot of this. So it's not surprising to me that there's are adjustments that can make these associations go away.
Yeah.
But again, if it also might be adjusting away the things that are, I don't know. I think you can also over-adjust.
Yes, definitely.
Yeah. So really hard to say, but really interesting stuff.
Yeah, absolutely.
I mean, also just look at this stuff. In the figure in H, you see that kids at 12 to 24 months getting 10 doses of antibiotics or 10 rounds of antibiotics. I mean, that's in a 1 year period. That's basically one a month.
I know.
That's a lot of antibiotics.
It is, definitely.
Yeah. Obviously, when you need antibiotics, it's good, but especially knowing how much, I'd say, polite controversy there is about some of the antibiotic prescribing for kids. For things like otitis media and even strep. It's really fascinating.
It is, definitely.
Yep, fun times. All right.
Okay, so the second paper... so this was looking at actually repeated antibiotic exposure by 48 months and its association with developing or having a higher BMI by age 54 months. So this was a cohort study also from New Zealand, although presumably it was a different population, or a different sort of cohort. And so they looked at 5,000 singletons. The investigators found that repeated antibiotic exposure in early childhood was associated with a higher mean BMI. And they actually looked at sort of different ranges of dispensings of antibiotics. And they found that word doesn't sound right, but I think that's the word they used. They found that more than 9 dispensings were actually associated with a higher likelihood of obesity compared with no exposure at all. So another sort of interesting, again, has some of the same sort of limitations, but another interesting investigation looking at this potential association.
Yeah, even some of the basic epidemiology to me was really, I think, some of the most interesting stuff here. So 9% of the children had obesity at age 54 months, which is a lot. That's 1 in 11.
Yeah.
That's a big jump. But out of the 5,100 kids, 4,886, so 95% had an antibiotic prescription by 48 months.
I know. I thought that number was pretty astronomical.
Yeah. I was trying to I don't think my daughter's had an antibiotic prescription yet.
Okay.
And she's 7.
Okay.
Which
well,
there
you go.
I'm proud of.
So it's interesting because then the other study looked at prenatal exposures too, and for women that are colonized with croup strep, for example, that's already gonna be your antibiotic exposure.
Yep.
So unavoidable.
And it's tough because there's so much babies with bathwater with this kind of stuff.
Yes, definitely.
Yeah, it's hard to make sweeping generalizations, but it was also interesting that the factors they found as covariates, or basically risk factors that modulated these. So there's a lot to read here, but the child factors included sex, birth weight, delivery mode, birth season, birth order, anti-reflux medication before 2 years, or excuse me, before 4 years.
4 years, yeah.
Sleep duration at 2 years. Time spent watching television on the last week or on the last weekday, watching television, DVDs, or videos at 2 years. Exclusive breastfeeding duration and dietary intake at 2 months or at 24 months. Maternal factors included age, relationship status, ethnicity, education, socioeconomic deprivation, self-reported pre-pregnancy weight, self-reported diabetes before or during pregnancy, alcohol use, and antibiotic exposure during pregnancy. So,
A lot.
yeah, and a lot of that is also either things that I think either directly or very closely correlate with socioeconomics.
Yes. Yes.
So there's a lot of stuff here.
Yeah, definitely.
yeah.
Now, were the videos VHSs or are these YouTube videos? I'm not sure.
Yeah.
Probably doesn't make a difference.
I don't know. I remember reading something recently though, or my wife's been on this kick. How interestingly, there's a pretty, a not surprising association between kids and watching TV, and movies, and obesity, but not with video games. And as somebody who plays video games, it makes sense because you're doing something with your hands. You can't. It's really hard to snack.
You have a conflict of interest there.
Yeah, it is, but it's hard to. I am biased, I admit it, but it's hard to snack while you're eating games.
Yeah, that's true.
Yeah.
That's
or
true.
it's hard to snack while you're playing games. You can't eat games. You shouldn't. All right, so moving on. So we've got the association of clinical characteristics with the variation in emergency physician preferences for patients. This by Cindy Chang and Ziad Obermeyer. It is really interesting research. So they looked at 294,000 emergency department visits between 2010 and 2015 at Beth Israel in Boston, and basically divided docs into low versus high quintile and a couple different things. And they looked basically at how doctors chose patients. So basically, lots of emergency departments do this in different ways. At the time, the way BI was breaking up their patients is there were just overlapping areas where any doc could pick up any patient at any point, basically. Except overnight, where there's only one doc who was going to see so they were going to see all the patients, excuse me. And they basically found that if you look at the different physicians, there are differences in the types of patients they pick up. And in this one, there was no financial incentives. It wasn't RVU based or anything like that. But they found basically a 2-year difference in age, 0.4 difference in Gagne comorbidity scores, and these differences went away at night when there's only one doc. Which is really fascinating.
That's really interesting.
Yeah.
Now, did this include? I can't remember if this was looking at residents or
this was just looking at the faculty docs.
Okay.
And so there's I think some mixing in here because some of it would be picking up which residents patients and things like that confound things a bit. Right. And there was also, when they looked at docs over in periods of times, some of the docs move quintiles across time. So you're not, the high quintile docs aren't necessarily always the high quintile docs and whatever thing.
Right.
The other thing that's really interesting to me is how when they looked at within the same doc over a shift, our practice changed too. So the emergency docs were more likely to pick up basically younger patients, actually 5 years younger on average by the end of the shift, and 0.7 on the Gagne comorbidity score less sick as compared to the 0.4 difference, which makes a lot of sense in a couple different ways. Where at the end of the shift, there's decision fatigue. There's knowing that you have less time to spend. Not with the patient specifically, but managing the patient over time. And that a lot of us, there's a reluctance to want to sign out complex patients in the middle of a workup if you don't have to. And, it's really easy to say pick up a cellulitis at the end of a shift versus, an 80-year-old with, 7 comorbidities and lots of things going on. So it was really interesting. And I think one of the main focuses of the research here, the way they framed it, was that a lot of health services research on emergency docs kind of assumes that you're essentially randomized to the physician, and they're basically saying that's not necessarily true, and that this practice variation may instead reflect preference variation to see different types of patients, and physicians who prefer sicker, more complex patients maybe order more diagnostic studies compared with physicians who prefer healthier patients. So it's not that there are docs who overorder or underorder necessarily, but some part of that may be what types of patients they tend to see.
The complexity.
Yeah, which is not terribly surprising.
Now, the other thing I can't remember was, I think they did talk about this. They looked at the physician's age too, right? And to see how that affected things. Now, I don't know, again, like anecdotally, I don't know what that could mean, but I think that's sort of interesting.
Yeah, and it's interesting. So in my place, where we are also similarly not reimbursed based on RVUs or productivity in any way, and we still get some of our metrics on how we do like patients per hour and RVUs per patient, RVUs per hour, and things like that, CT use, admission, et cetera. But what's interesting is because of the way we divide our ED up into different zones and basically have like a fast track versus like the highest acuity stuff like that, I would guess that almost all of my variation from quarter to quarter just has to do with like how many fast track shifts I work versus how many like trauma shifts where the chances of somebody who's like a level 1 trauma and they're going to get 5 CT scans. That's true. So and I think because nobody actually does anything with these numbers other than look at them, and there's no dollars behind or anything like that, we don't take the time to adjust them. So it's just like going to welcome a bunch of people who've joined. Sorry, Matthew, Paul, D, and Mountasser. So welcome. We're doing our rundown, just finishing talking about ED docs. I'm really curious how this would be different among docs where there are productivity incentives.
Yeah, absolutely, right.
Yep. So I try to not let that stuff affect me at all. But like we've talked a number of times about say distal radius fracture reductions.
Yes.
And I generally think that a lot of the pendulum swinging, and we're going to be doing a few and a few of those over time. It's 5 RVUs.
Yeah. Oh, really? Yeah. Wow. Okay.
Yeah.
There you go.
Yeah. All right. So what do you have next?
All right. So something that I don't know much about, but I actually really liked it. I thought it was really interesting. So this is assessment of mandibular movement monitoring with machine learning analysis for the diagnosis of obstructive sleep apnea. So this was trying to assess or evaluate whether monitoring mandibular movement during sleep, and then using machine learning to do that actually works for the diagnosis of OSA. And part of the background behind this is I think, the way that we kind of test for OSA right now is really cumbersome and resource intensive, et cetera. So they looked at 376 adults with suspected OSA and essentially did an automatic analysis of the mandibular movement, with the machine learning kind of evaluation, and then compared that to sort of the standard polysomnography results. And you can see this in figure 2 because it compares the reference to this sort of new alternative technique. And they found that this technique using mandibular movement provided reliable performance indicators, especially in calculating what needs to be calculated to determine whether a patient has OSA. So just another sort of application of machine learning in sort of a really interesting way, I thought. And I really liked I always like the graphs are pretty, but I liked this one a lot.
Yeah, these figures are great.
It was cool.
And figure A I think is nice because a lot of times I think like they report the area under the curve, which is nice. It's 0.95 and 0.93.
Yeah.
But a lot of times I feel like those aren't terribly meaningful. One is I think it's like specificity where the numbers that sound really good aren't quite as good as they sound sometimes, especially if the distribution is not equal. But what they did, like, if you're trying to predict a rare event where most people are okay, like everybody who's doing okay is going to make up most of your error in the curve.
Right.
What they did here is they do 3 different curves of patients who don't have OSA, and then 2 different curves. You can see in the top of figure 2A, 2 different curves of different levels of OSA, and they show like, look, here's the curve from the criterion standard, and here's the curve from our new machine. And I think that's a really interesting way to do it. That's it appears to me to have more face validity than just like, hey, look, if you plot sensitivity versus specificity,
this looks
numbers.
pretty good. Yeah.
I also really like the Bland-Altman plot they put in figure 2B.
I do too.
Which before I get into that, I'm going to welcome Oliver Bueno and Almaz. You joined just in time for me to do a bad job explaining Bland-Altman. But basically, what Bland-Altman does is the x-axis is the average score between the 2 different things. It's basically a way to compare 2 different measurements of the same thing. So the x-axis is the average measurements. So at each score, and so as you get a higher, it's the readings that are the high score. And then the y-axis is the difference between the 2 scores, and basically what the disparities are. And what you can see here is that as you get higher and higher scores, whichever score is the second one is actually tends to be lower than the other one. So there's kind of an overall slight bias towards lower at the higher end. And this is the kind of thing where, again, I'm not a huge expert in bland Altman, but from what I've read about it is traditional scores like the IRR, inter-rater reliability, like is it the Pearson or Spearman? I always forget which one. I think it's Pearson.
I think it's Pearson.
I think it's Pearson.
I think so.
One of those, again, it just can overestimate it, especially at the higher end. It can overestimate or overrepresent, like really nice sounding scores like 0.7 or 0.9 aren't necessarily as good as they sound. I will say if you're interested in bland Altman at all, the people who can do a much better job explaining this are Bland and Altman. Their original paper is actually really, maybe it may not be the paper, but some essay that they wrote that explains it all. It's actually really readable, and it's like we took home like flow cytometers, no, it was peak flow meters at like Christmas on our Christmas vacation, and had our family members all do flow meters, and we showed like the difference, and they do little, and it really walks you through. And I'm doing a terrible job explaining it now.
No, that was great.
But it's interesting. So welcome Hada Masiri and Kai Chen, who've joined us to hear me, and Almaz, who hear me do a bad job explaining complex statistics.
But you cited the reference.
Right. Bland Altman, it's also, I also like it with, this is one of those things where I really like it when like the original people who did it have like a readable, approachable thing, and it's not like some technical like 80-page tome.
Yeah, that's true.
All right, so last up, we've got an interesting one on comparison of mortality and major cardiovascular events among adults with type 2 diabetes using human versus analog insulins. So this is interesting because I don't really prescribe a lot of long-term insulin for people, fortunately. And basically, there's a big price difference between human and analog insulins. There's been concern, at least from the lack of data, if not concerning data, about rates of serious hypoglycemia in recent reports. And the WHO says that there's just kind of a few methodologically rigorous studies comparing the two. What they did in this study is looked at 127,000 adults with type 2 diabetes from Health Partners in Minnesota, and then 3 Kaiser Permanentes in Colorado, Northern and Southern California. Looked at overall mortality, cardiovascular mortality, MI, stroke, and CHF, or CHF hospitalizations, and they found no differences. So if you look at figure 3, there's basically a nice curve showing really no differences over time in those big outcomes. We've got the visual abstract too that shows the adjusted hazard ratios, and just overall, there's a kind of, I don't know, some might say a slight trend towards worse outcomes in some of these in the human insulin, but 127,000 adults and pretty wide confidence intervals that cross one pretty consistently across the board. It seems very unlikely that there's any sort of effect here.
Yeah, no, definitely. Yeah. That you actually said all these things.
Yeah. No, I mean, good studies are simple, and there's not a lot to talk about.
No, it's great. I like these kinds of things. It's like these are such common issues, and so it's kind of cool to see another machine learning paper used.
Yeah. Oh, I forgot to say for your machine learning paper, the thing that's cool about their with the machine they use to do the mandibular movement, it's a coin-sized hardware attached by the sleep technician to the chin of the patient in the mentolabial sulcus, which is the little angle where your bottom of your lip hits the top of your chin.
Yeah.
And if you look in a profile, I have a beard, so it's hard to see, but there's like a little sulcus right there, and you just paste this little thing there. So instead of doing like all the EEG type things,
right. So ideally, at some point, could you maybe even do this at home?
That's what it sounds like to me. Down the line, might be able to be done, and it can be really hard and burdensome to get a sleep study, and plus, I'm sure it's somewhat artificial, and that you're not at home. In your
exactly. Place. That's the thing I always worry about with sleep studies, because it's just one night typically, and it's in a place that you're not really used to being. So it's probably I feel like most people would have a terrible time sleeping.
Right. Well, I guess you're finding the worst case scenario.
Yeah, that's true.
But it also just seems, I just know I've been, like, when I worked in residency at a public hospital in New York, it was also patients were waiting like 6 months or longer to get sleep studies.
It was so tough to get them in. For sure.
So it's hard stuff. All right. Well, thank you for joining us. Join us next week, of course, 3 p.m. Central Time on Tuesday for more JNO Live. Follow us on the usual social media channels. You can get the author audio portion of this on podcast through your iTunes or wherever else you get your podcasts. And, of course, Wednesday, tomorrow, and Friday, 10 a.m. Central Time, get the new releases of JAMA Network Open Content, where everything's free and open access.
Thanks, everyone.
Great.
Have a great week.
Take care.